is the treatment programs for continuous and lifelong suppression session. And thank you everybody for joining. It's really exciting to be able to share this session with you. We have 3 presentations ready and geared up, presenters ready and geared up to share some of their experiences in the Third 95 area. My name is Lana Lee. I'm one of the medical officers in the adult clinical branch here at OHA. And I am accompanied from the OHA side by Lindsay Bonanno, who will be moving the slides. She's from our local partners team, as well as Margaret Cunningham, who is also part of the adult clinical branch, who will be helping to take notes. And they will also be helping to me with moderating some of the, or facilitating some of the questions and discussion points in the chat. So let me first start off by introducing our 3 presenters today. We have Dr. Samuel Kiria. He is a devoted medical doctor with over 14 years of experience supporting healthcare improvement through PEPFAR-supported programs in Uganda, and his technical expertise includes program management and capacity building for regional, district, and health facility teams through training, coaching, mentorship, and application of performance and quality improvement. He is currently working as the HIV/TB specialist in the USAID's local partner health services, Kigezi. And this is an activity managed by JCR, the Joint Clinical Research Center in Uganda. And so Samuel is going to be, he also provides technical guidance to the project and district teams in planning and implementation of HIV and TB prevention and treatment interventions aligned to PEPFAR, USAID, and the Uganda Ministry of Health policies and guidelines, and participates in monitoring, reviewing progress to ensure effectiveness and implementation and achievement of project targets. So he'll be speaking to us today about how leveraging district resource persons to fast track improvement in ART regimen optimization for children, adolescents, and adults in the Kigezi region in Uganda. Next, we will have Ms. Isabel Mendesiamba, who holds a master's in development program specializing in health. She's a dedicated health and economic development specialist with over 15 years of experience managing the design, implementation, and monitoring and evaluation of large health programs in Namibia. Technical expertise includes HIV prevention, is broad, HIV prevention and treatment, sexual and reproductive health, training and capacity development, OVC care, TB care, malaria, and WASH. And she's currently working as the chief of party at IntraHealth Namibia, overseeing the KP STAR project. She currently provides overall leadership and management of the project and provides strategic guidance and vision in coordination with a senior team of technical, finance, and M&E staff. Our final presenter will be Ms. Braxides Mayero. She is a clinical officer at AMPATH, and she will be speaking on the role of psychosocial support groups in monitoring viral load uptake and suppression among persons living with HIV with alcohol use disorder in the Saboti Sub-County Hospital, Trans-Nzoia County. And she serves as a clinical officer, is currently based in Kenya, has had 11 years of programming experience in HIV and TB, and has been with AMPATH Plus now for the past 3 years. And before we get started, I'll just say that, we all know that achieving continuous and lifelong suppression is the ultimate goal for any person living with HIV in order to meet healthy and optimal long-term outcomes. And this is the ultimate goal of PEPFAR, for us to see and ensure that everybody has, all the people that we serve who are living with HIV are able to access medications in order to achieve this final, this ultimate goal, clinical goal of achieving lifelong suppression. And so really excited to hear from all 3 presenters today. Before we get started, just to let you know the agenda, we'll start off with our 3 presenters. And then we will move into a period of discussion and questions. But I really encourage everybody during the course of the presentation to please feel free to put in any questions or discussion points that might come up for you during the course of each of the presenters. And I already see people putting in their names in the chat as well as their affiliations. So please I encourage you to do that as well, so we know who is on the webinar or on this session. So with that, Lindsay, if you can go to the next slide. let me once again introduce Dr. Kiria, who will be speaking on his experiences of leveraging district resource persons to fast track improvement of ART regimen optimization in Uganda. Dr. Kiria, over to you.
Thank you very much, Lena. I hope I am audible. Sorry, my camera video could not work, but I'll go ahead and share our experience from Joint Clinical Research Center in Uganda. Joint Clinical Research Center is a local organization founded in 1991 as a partnership between Ministry of Health, Makerere University, and the Ministry of Defense to respond to the HIV pandemic. With the initial scope of work in research, the scope of work over the years has evolved to capacity building through training and coaching activities, as well as supporting regional rollout of treatment. We were the first implementers in the PEPFAR program, rolling out ART in Uganda from 2004. And since then, we've played a pivotal role, not only in research, but also in capacity building and healthcare. So currently, we are implementing a USAID-funded project, which are initial scope of work in Kigezi, southwestern Uganda, where we cover 6 districts and 78 facilities. But later on, the scope of work was expanded to Lango region, where we have an additional 9 districts and 59 public health facilities therein. So the work I'm going to share is our experience about regimen optimization as a contribution to the optimal lifelong suppression. Next slide, please. So the context is that the Ministry of Health guidelines updated in 2020 following WHO guidance and other research recommended that patients need to be optimized to DTG-based regimens as the preferred choice. And so when we started our project in Kigezi region, we had a target to reach out to over 7,000 individuals across the 6 districts to be reached through 78 public health facilities. In Q1, the first month of our implementation, we had suboptimal implementation on the target, attaining only 5%, and this caused us to institute measures to be able to get on course and achieve this target as the year progressed. The main reasons for the poor performance at the end of October were around knowledge gaps amongst the healthcare workers on the DTG eligibility criteria and periodic stockouts of the DTG-based regimens. As I'll be sharing, our main interventions were really focused on addressing these challenges. Next slide, please. So the main interventions we put in place were capacity building to address the knowledge gaps and performance monitoring. We conducted on-site training in November and October as a strategy to resolving the knowledge gaps that were persistent, that were existing amongst the health workers, and that was followed by hands-on technical support working with the facility teams during clinic days to make sure that we reduced opportunities for patients who are eligible going away without being transitioned or initiated on the preferred regimen. And we did not do this alone because the project staffing is not that big. We leveraged the district resource persons in whom we invested through training. So we built the capacity of the district trainers and mentors through regional training of trainers workshops. And following that, they were able to pursue the on-site training with, of course, the facilitation of the project. Following the initial training, we were able to conduct on-site mentorship and coaching during the period January to February. And as I'll be showing, this made us make some progress. We were also able to, at the health facilities that we support, conduct health education talks for clients and caregivers to inform them about the new regimen and its better tolerance as well as effectiveness in optimizing suppression. And we worked with the facility teams to review the patient charts, line list clients who are eligible to DTG optimization, and they were able to provide pre-clinic appointment reminders to the clients as a strategy to make sure that they do not forget or we mitigate the challenge of forgetting as used to happen. We also supported the facility teams to place timely and correct orders for the ARVs, including the DTG-based regimens, because one of the challenges was stockouts attributed to inadequate quantification and ordering during the ordering cycle. So through the national warehouses, we were able to have the facility teams submit their bi-monthly orders and follow up after the deliveries to make sure that whatever quantities were ordered had been delivered. And if there were any back orders, we worked with the national medical stores to fast track the making good of the delivered quantities. We worked with the facility teams to conduct weekly performance reviews. The annual targets were broken down into quarterly targets, monthly targets, and weekly targets for each of the facilities. And so on a weekly basis, we were able to track progress against the targets at each of the facilities. The captions here are just those of some of the activities that we implemented. As part of the on-site training, we had CMEs where health workers were updated on the provisions of the guidelines, and the chart, the lower picture is just showing the chart review exercise to identify clients who are eligible for transition. Next slide, please. So this run chart is just to show the progress that we made over the period. So following the training, which we conducted in November, December, we were able to register a steady increase in the number of patients who were transitioned and initiated on DTG-based regimens. The dip in week 50 to 53 was mainly because of the appointment system which we implemented, given that during Christmas time, both health workers and clients needed to be away. The appointment systems were such that there were fewer patients on appointment for this period. And so immediately after that, we were able to regain course and steadily progressed. The black line is just to show how we were performing on the trend, and we can see that by end of June, the backlog had been cleared. We did not close shop. We've continued to support optimization for those beyond the target that was set, and the new ones that have been enrolled since then. Next slide, please. So this is just to present the trends across the supported districts. The key message here is that, for example, in Kabale district, we picked up at week 49 and dipped a bit in the Christmas period. And this is a consistent picture across all the districts. So the 78 sites that we support are spread across these 6 districts. So the key message is we were able to have all the districts through the district coaches and mentors to have incremental progress on the numbers of patients optimized to DTG. And as we can see, by June, as I mentioned earlier on, nearly all the districts had surpassed their target. In other words, they had cleared the backlog, and we were continuing to implement the routine optimization beyond the targets that were set. Next slide, please. So the best practices that worked for us in this undertaking are that we worked collaboratively with the above site mechanism from which we are transitioning, that's Right Southwest program. And the collaboration enabled smooth implementation of the trainings to address the knowledge gaps, and also supporting the medicine management system to be able to have the drugs available to the facilities. The district management supervisors are a team that we routinely work with, their district staff, but with the facilitation of the implementing partner, they support the respective facilities during the ordering process, and they support in following up to ensure that if there are any non-deliveries, those are effected. So these resource persons at district level were pivotal in enabling the progress that we registered. The training of the health workers inevitably made a significant contribution, as mentioned, and the on-site technical support by both project staff and district resource persons enabled line listing and follow-up, pre-appointment reminders, and immediate transitioning through prescription, and making sure that the team that does the dispensing provide the medicines. We're also cautious about the adverse events, so we supported the facility teams to implement the eligibility screening and getting the patients prepared for that. We're able to roll out the use of the HIV care audit tool, and that helped in the identification of patients who needed to be optimized. Teamwork between the clinical and pharmacy staff also enabled the progress. Next, please. I'm wrapping up. Right, so on the platform for pediatric regimen optimization, as we implemented the regimen optimization, we remained with some priority children who had not been optimized, but we were able to work with the facility teams and district resource persons to have these cleared by end of September. So finally, next slide. In conclusion, if the local partners intentionally build the capacity of district resource persons and facilitate them to provide the needed technical support to the site teams. This will make us achieve the results that we desire to achieve, and at a very cost-effective, in a cost-effective way. Thank you very much.
Great, thank you so much, Dr. Kiria. Appreciate that. Next, we'll again, if you have any questions, please put them into the chat function or any discussion points that you'd like to raise, and we'll address them at the end once all the presenters have presented. Next, we will have Ms. Isabel Mendiciamba, who's going to be talking about the utility of U=U HIV prevention messaging and viral load suppression among key populations in 10 priority geographic areas in Namibia. So I'll hand it over to you, Ms. Isabel.
Thank you, Lana. As introduced, Isabel. I'm going to share the experience of the Key Population Project, KP STAR, implemented under IntraHealth Namibia, on the utility of U=U HIV prevention messaging in viral load suppression among key population in 10 priority geographic area in Namibia. Next slide. Okay, this is the outline of my presentation. I'm going to look at the background, methodology, results, and then conclusion. Next slide, please. Okay, the 2019 Integrated Biological and Behavioral Surveillance Survey indicate poor viral load suppression, ranging from 28.3% to 77.2% for female sex workers, and for MSM ranging between 30.5% to 53%. Okay, studies have proven high viral loads lead to higher rates of HIV transmission in both sexual and mother-to-child transmission. So while the project started, which started in April 2020, the emphasis was actually on U=U HIV prevention messages. Next slide, Lena. Okay, what methodology did we use in order to ensure that the U=U HIV prevention messages is utilized or is conveyed across the board in all the PGAs or prior geographic areas or districts that we implement? So training of peer educators and case managers to use the flip charts to give a minimum package of HIV prevention messaging. With that, it was important to ensure that all the peer educators have the messaging. So with that, we introduced the U=U HIV prevention messaging in all our trainings for field officers. So peer educators were trained to use the flip chart at all levels of engagement with the clients. We also then the case management component enroll clients on case management to support adherence. So as adherence is very critical to ensure viral load suppression. So during the case management component, adherence counseling and treatment adherence were done with the clients, and also at that same platform or that same venture, the Quick Res, which is an online platform that enables clients to assess their services needs, book health services, and receive viral load support, was also visual support was also introduced to the client. So this platform assists or helps clients to do their own reservation online, and also for them to own their own appointments. And telephone interventions were also done following up, and at times also home visits were also conducted to ensure that the clients were supported. So as you can also see on those slides, we have a client, one of the case manager with a flip chart providing information on U=U messaging. We also have one of our trainer there providing information, especially training, re-emphasizing on the U=U HIV prevention messaging. Yeah, okay, and we have also done a lot of the HIV prevention message, which comprise of U=U message in view of viral load suppression. So this is actually the daily talk of the peer educators the case managers with the clients at all level of intervention, starting from interpersonal communication sessions through case management. Next slide. This slide shows the result for a period of 12 months in 4 districts out of the 10 district or priority geographic area where the project was implemented. Over the period of 12 months, 13,128 sex workers were recruited, of which 96% of those were recruited tested for HIV. 98% of those who tested positive for HIV were linked on ART, and 67 of them were eligible for viral load monitoring, and 63 of those who were eligible for viral load monitoring had actually a suppressed viral load suppression. That is about 94% of those who tested positive. For men who have sex with men, 4,056 were recruited. 90% were tested for HIV. 98% were successfully linked on ART. Of that, 15 of those who were eligible were eligible for viral load monitoring mycology, and 15, which represent 100% of those who were eligible for viral load monitoring had a viral load suppression. Next slide, please. In conclusion, incorporating U equals U messaging into HIV prevention and case management motivate adherence and viral suppression. With that as a project, we have started sharing the results with the Ministry of Health and Social Services and also with the technical working group. Recently, the U equals U HIV prevention messaging is being incorporated also in the treatment literacy curriculum for the Ministry of Health at a national level, which will then be cascaded using the guideline also to cascade the information in all districts at the Ministry of Health and Social Services facilities. And it's also important that we have trained peer educators and also do effective case management, which is really important in order to ensure the U equals U messaging is enhanced at all levels. So it's very important that peer educators are trained, case managers are trained, and also as emphasized in the beginning, that all the field officers, even those who are overseeing the case managers, who are overseeing the peer educators, are actually trained and have the information on U equals U messaging to ensure viral load suppression. I think that's the end of my presentation, and I look forward for questions. Thank you so much. Over.
Great, thank you so much. Thank you for sharing your experiences around U equals U in case management. Okay, so our final presenter before we go to discussion is Ms. Praxidis Mayero, who's going to be talking about the role of psychosocial support groups in improving viral load uptake and suppression among persons living with HIV with alcohol use disorder in Kenya. So over to you, Praxidis.
Thank you. I actually work for Empath. Initially it was Empath Plus, right now it's USAID Empath Uzima. Empath basically is an academic model that is providing access to healthcare, and it's supported by USAID under Moi Teaching and Referral Hospital in collaboration with Moi University College of Health Sciences, with an aim to actually provide sustainable efforts in access to healthcare, which is in Kenya. And it's currently supporting 6 counties within Kenya, having Trans Nzoia County as one of the counties that is actually supporting. And Saboti Sub-County Hospital is in Trans Nzoia County under Saboti Sub-County. Next, kindly. So, Saboti sub-county is actually in a rural setup, and the facility itself is actually in a rural setup with alcoholism, or rather alcohol use disorder, being part of it, especially among our clients. So basically, for us to achieve viral suppression, it is important for clients actually to adhere to their medication, or rather to their ARVs. And the use of alcohol actually deters adherence to medication, which basically means they will not be able to suppress when it comes to viral load. Studies have also demonstrated that it is for someone to actually be adherent, they need to factor in everything else, inclusive of viral load, inclusive of reducing alcohol intake, or rather just reducing, completely stopping the consumption of alcohol. Next, kindly. So last year in the month of February, we actually realized that our suppression in terms of viral load was very low. It was actually at 86% and an uptake of 13.7. And the fact that we had actually seen some good efforts in terms of use of psychosocial support group, in terms of improving client outcomes, we decided to leverage on the use of psychosocial support group for this particular cohort of clients. And by looking further, we actually realized that quite a number of our clients were alcoholic. It is at that point that we said, let us have a separate group just for these particular clients, so that we are able to support them as a special cohort of this particular client. So basically what we did, we decided to center on patient level, or rather client level, so that you are able to support them. Next, kindly. So majorly our objectives was to improve the viral load uptake among these particular clients. As I had mentioned initially, the uptake was actually low at less than the 95% coverage. And at the same time, the suppression among these particular alcoholics was actually very low at 7.7%. So we really wanted to improve this to above 90%. Next, kindly. So it was a multi-approach whereby the clinician played a part in terms of identifying the clients by screening them using the CageAid screening tool. At the same time, we also had peer educators. So for the peer educators, they were also able to identify the clients that had been missed out, in the essence that they're actually coming from the same community. They're able to identify the clients that are taking alcohol, and through screening, probably they just decided to probably give minimal information. So they also supported us in that. So we were able to identify 19 clients. Interestingly, we had 10 females and 9 male that were actually identified in total. Thereafter, we actually gave them just encouraged them of, we assured them of confidentiality and privacy, so that they would be able to consent to the issue of psychosocial support group. Next, kindly. So when they accepted to, we gave them phone calls just to start off the support group. So when they accepted to come to the facility before their clinical appointment date, first, we gave them an unjudgmental attitude, so that we would be able to really break the ice and be at par with them, and by that we'll actually be able to create rapport with them. Thereafter, we harmonized their clinic dates, so that we would not have separate dates for psychosocial support group and separate clinic dates for them, so that it will coincide just with their clinic dates. And during the support group, because they actually come from more or less the same locality, we encourage them to have treatment supporters among themselves, so that they would be able to really support each other in terms of adherence. And subsequent meetings, we were able to have treatment literacy sessions with them. And at the same time, we also had peer case management, in that because they had already identified peers among themselves, they would be able to give a report of how each one among them, how they are faring on. Being a treatment supporter, they'll actually be able to give a report how each one of them is faring on. And at the end of the day, they will also give individual reports in terms of how they are faring on with their treatment and any other issues. And the clinician would actually wrap it up after they are done, just to address the challenges that they would have raised and they were unable to really give solutions among themselves, would be able to support them appropriately, so that by the time the meeting is over, they would actually leave when they are very much comfortable with the issues at hand. Next, kindly. Sorry, this slide is not so clear, but on assessment, in terms of at the beginning of the psychosocial support group, we had 19, and at the time of submitting these, actually the number had increased to 34 clients. Basically, it was now self-referral. They actually encouraged their buddies to join in the group. So because the number is large, the groups are now 2, just to support them. And when you're looking at viral load uptake and suppression, you actually realize that the uptake has increased to 100%, and suppression is actually high, with only 1 client who is not suppressed. Actually, this is a client that is failing on second-line treatment, and we have been able to summarize just the client, so that we support them on the the regional TWG, sorry, technical working group. So basically, next kindly. So basically, the clients have really improved when you're looking at their outcomes. And just as I had initially mentioned, we actually see that we have now 17 female and 15 male. And the uptake is actually well, as I had mentioned, at 100% from 86.7%, and an improved suppression from 7.7%. Next, kindly. So, sorry, that was a typo. There's in terms of suppression, but you look when you're looking at that, suppression has improved. And additionally, we have had 100% retention. None of our clients has actually dropped from TXCAR. They're all active. And the fact that there is peer support, they're actually supporting each other just beyond adherence. So the suppression is actually very well, and also the retention. And basically, in terms of continuum of care, all indicators of this particular client is actually fair, or rather at its best as we speak. Next, kindly. So just to note, we had a few challenges. Most of the time, clients, when it comes to alcoholism, they actually start with they will actually stigmatize themselves even before the clinician or rather the healthcare workers stigmatize themselves. So that was a very big challenge. But as I mentioned earlier, because of the ice breaking and all the rapport by the clinician and even among the peers, we were able to sort that challenge. However, as we realize, as much as we have been able to do well in terms of suppression, uptake, and all other indicators, only 3 clients have been able to stop taking alcohol within that year. So somehow that is a skill that we are still trying to work on, so that you're able to support them wholesomely, apart from just the HIV aspect, we also need, we are also really doing our best to support them in terms of rather, instead of reducing alcohol, just to stop completely. Next, please. So in terms of conclusion, I actually feel that psychosocial support group can really support our clients. And apart from that, is actually a very inexpensive method, because when they're coming the facility during their clinical visit, at that point, we're actually able to just have them aside and talk to them and interact with them, so that we are able, apart from just them taking the medication and the other lab investigation that is required of them, we're actually able to support them at that level as a group, just after they are able to take their treatment. And at the same time, we also realize that treatment outcomes across board will improve when we have psychosocial support group. Thank you.
Wonderful. Thank you so much to all three of our presenters. I'm wondering if, as we move into the discussion section, I think one of the things that we wanted to hear from all of you, we do have some questions coming in. Just wanted to encourage you to, again, sort of put the questions in the chat function or in the Q&A function if you have a moment. One of the things I'm wondering if, you know, in these three presentations, we've seen quite a broad set of interventions to get to achieving viral load suppression. We had, you know, Dr. Kiria presenting his experiences, or Uganda's experiences, with the transition of ARV optimization, the medications people are taking, and really rapidly scaling that up. I think that, you know, with both Braxity's and Isabel's presentations, it was nice to see how interventions may be being tailored to specific populations that may historically have difficulty achieving viral load suppression, both key populations and those with substance use disorders. And I think that, you know, the interventions with regards to U = U messaging and case management, or and psychosocial support groups are interventions that are used very commonly for most populations. So, you know, I think it's helpful to know some of the details behind how things get tailored to specific groups. I'm going to maybe start off with Isabel with Braxity's, just going backwards, to ask the first question. This is from Jacqueline Devine. She was asking, you know, since clients, men in particular, may perceive that they need to choose between drinking and taking their ARVs, what harm reduction approaches did you use, for example, to planning when to take your pills before they go out?
Thank you, Lena. Actually, what we did just to encourage them, most of them actually admitted that they take their alcohol late in the evening, or rather in the evening. So first of all, they're on, apart from one client, all of them are actually on a once daily regimen, TLD, tenofovir, lamivudine, and dolutegravir. So we actually encourage them to switch. Those that were taking their medication in the evening, we actually encourage them just to take their medication in the morning, so that by the time the day goes by the time it reaches evening, at least the medication will have been in the system, so that they would be comfortable enough to take the alcohol. Because of course we couldn't just tell them to stop taking the alcohol at that point. So that is how we actually encourage them, because if we had told them to stop taking the alcohol and concentrate on the ARVs, when they came in, they were actually, you know, they already had a formed opinion. The doctor usually tells us not to take alcohol and to take ARVs. So that is the best way. We actually just told them, check in the morning, and later on in the evening, you can take your alcohol. And on top of that, there are some that actually had come up with complaints, especially when you had just changed them to TLT, that anytime they would take ARVs, they would vomit. So additionally, on top of that, when we gave them the option of time, they were thrilled and they would take. And because of the treatment supporter aspect, they would actually encourage each other when they have gone to the drinking dens. Did you take your medicine? So at that point, that really worked for us. Thank you.
Thanks, Praxidis. Ms. Isabel, we had a few questions several questions actually come in, but maybe just to start, I was wondering if you could also talk a little bit about some of the lessons that were learned on how best to explain U equals U in non-medical terms. I know this has come up often when we're talking about treatment literacy. How do we effectively communicate U equals U? And I guess another question on top of that, if you can also answer this, is what are some possible hesitations among case managers to overcome on conveying U equals U to clients, and how did you overcome them during the training?
Okay, thank you, Lena and the participant for the questions. I will explain on the questions on how we explain the term U equals U in the layman's term. So what we do, or what the peer educators or case manager will do, they will just in a simple form explain that a person that takes treatment daily on time, the amount of the virus is pushed down. Yeah, because it's pushed down and the body is working. That show that the body is working, and the chances of then giving the virus to the other person is reduced. So that's what we explain in the layman's language. And on the hesitation of the case manager, we don't really experience hesitation, because the message of the U equals U HIV prevention is actually reinforced at all levels, including we have weekly verifications, and we are also having online platforms done on a monthly basis with the case manager. So we didn't really experience any hesitation by the case managers. And I think there was also a question on the prevalence rate for the general population. According to the Namibia report, the prevalence rate for the general population stood at 12.6%. Thank you.
Great. Yeah, there are some other questions for you in the chat. We'll try to get to them if we can, but I do also want to raise a question for Dr. Kyria. There was a question about, first of all, thanks. This is, I'm not sure who this was from, but the question was, you know, as presented, the two key factors for achievement are capacity building and collaboration, which is great. But the person who was asking wanted to hear more explanation on the collaboration part. And I think this is a really important question. How were you effective? How are you effective in collaborating with the government? And did you face any challenges in connecting to this? So could you please share some of those challenges and how you overcame them?
Thank you very much. I have colleagues from other implementing partners in attendance, and they'll probably complement to what I'll submit too. And I've been on USAID funded projects for several years now. And as part of the mechanism conceptualization and award, deliberate efforts are made by USAID to introduce the implementing partner to the Ministry of Health. As an implementing partner, we do not have any health facilities of our own. And so the implementation has to happen within the national health system. And so at national level, we have focal point persons to work with at the Ministry of Health, for each of the implementing mechanism, and this assures that the Ministry of Health priorities are addressed during the implementation. Each implementing partner has a memorandum of understanding with each district, and through that, there is agreement on what will be done by the district. For example, the districts recruit all the health workers. If the implementing partner comes in, they will only complement on the existing health workers. So that is very well outlined in the collaboration mechanism. And so in terms of medicines and supplies, the government of Uganda certainly is responsible for providing all the essential medicines and supplies. And when implementing partners come in, they are only complementing to that. So from design through award, planning, implementation, and monitoring, there's a very tight, deliberate collaboration undertaking, and mutual accountability is one of the principles. So during planning meetings, performance review meetings at district level or even site level, the implementing partner is working tightly with the entities, whether central or local government. Thank you.
Thanks, that's great. I actually also had a follow-up question because I was wondering whether, sort of along the lines of the government, understanding your relationship with the government, with regards to the district resource person, were these existing health cadres within the government workforce, or are they individuals that were selected? Just trying to get a sense of what their qualifications were and whether it was their role was specific to the TLD transition, or if they have other roles within the HIV program.
Right. So the district resource persons are staff employed by the local or central government. For the regional referral hospital, we have resource persons who are paid by central government. In the districts, we have resource persons who are part of the government. These are assigned different roles. For example, we have PMTCT focal persons and mentors. We have TB focal persons and mentors. And so in each thematic area, there is a team that has been designated, and we build the capacity of that team to be able to drive the agenda at hand. So these district resource persons are employees of the government, and we only come in to enhance their capacity and facilitate them to play their roles.
Great, thank you. I'm going to ask one more question to Isabel, and then another question to all of you. But first, a question to Isabel. Dr. Felix Iwala was asking, achieving U equals U is a milestone, and maintaining the status is a desired requirement for all clients. But he wanted to know if you had any economic packages that were supportive of indigent children, adolescents, or people living with HIV to sustain their U equals U status. In your case, specific to KP populations, but if some of the other individuals, or some of the other presenters also know of economic sustaining packages, then please feel free to also mention it.
Thank you, Lena. At this moment, no, we are not having any economic initiative in the project. So in the project, what we do is we identify the client, we support them, we test them, link them to care, and continue support. That's all that we do in the project. Yeah, thank you. I don't know whether I've answered your question entirely.
Yeah, no, that's fine. I know that within PEPFAR funding, economic strengthening tends to be within the OVC programming for children and adolescents in particular. And so, the funding for other economic packages may not be as available within other I do have, and this is for all of you, a lot of your work with regards to training of healthcare workers, or with meetings of individual, caseworker to case manager to client, or peer support groups, I'm sure was affected by COVID-19 pandemic. And so I was wondering, one of the questions that came out was, how did the COVID-19 pandemic affect the trainings and the rollout phases for each of your projects? And how did you handle this challenge? Because I think that, it's an ongoing challenge in many regions. And so it'd be great to hear how you've managed to overcome and sustain these interventions. Maybe we'll start with Dr. Kyria, and then Isabel, and then
yeah, thank you. Certainly, at the time we came into the region in October 2020, the country was just recovering from the first wave of the COVID-19. And at that time, we had to take very precautious measures to be able to reduce the risk of transmission. And so in the trainings that were conducted, a lot of effort was made to make sure that the trainers and the trainees all adhered to the infection prevention protocols. And so for the didactic trainings, we limited the number of trainees. And then for the on-site equipment utilization, as well as making sure that we do not congregate many health workers as part of the prevention protocol. Of course, during the implementation, as we continue to improve the performance, another wave came in around May 2021. But fortunately, by that time, we had many of our patients.
Oh, we might have lost Dr. Kyria.
Wow.
Maybe give him a few more seconds to see if we hear his sound return.
Oh, Lana, he was speaking, so I don't know, maybe your internet cut out first.
If not, maybe we can go to, let's see, Rhapsodies, Ms. Isabel, would you, oh, you can hear him. Sorry about that.
Okay, thank you. I think that's actually a good question. For Namibia, the projects actually started.
Yeah, so this was to when the second wave.
Samuel, why don't you finish, Samuel, what you were saying, and then we'll see if we can make sure that Lana hears everyone.
Yeah, so when the second wave of the pandemic hit, because of the restrictions that were instituted in terms of public transport and movement across facilities, we had to institute home delivery of medicines for the health workers who had gotten waivers, whom we assisted to get waivers for travel amidst the COVID restrictions. Thank you.
Great, thank you, Samuel. Isabel, please go ahead.
Thank you, Lindsay. I think for Namibia, it's actually interesting to say that the project started just a few days after the first lockdown was announced. So as a project, we had to come up with innovative measures to ensure that we continue doing our work. So we introduced Quick Res, which is an online platform that enables clients to assess their services needs book health services, and receive visual support. So that platform was vigorous, implemented. We trained our peer educators, case managers, site coordinators on the usage of QuickRes, and was also populated using various social media fora such as Facebook, WhatsApp platforms, and Instagram. So that's what we did actually during the implementation. And also for those who tested positive, we also continue monitoring their appointments via online. And also we gave like case managers telephone support, follow up using their cell phones. I think that's on the KPSTA project. Thank you.
Great. Thank you very much, Isabel. Praxidis, would you like to contribute on how your program was able to adapt to the COVID-19 pandemic that Lana was asking?
Thank you, Lindsay. Majority of our meetings and even trainings were actually online. And the good thing is that every Friday for our program, we usually have CMEs that all the facilities within the supported counties join in. So this actually was not a new thing for the program, because we just switched from now physical meetings to virtual meetings as a program. And additionally, where physical meeting was really mandatory, we were restricted to a maximum of 15 persons per meeting, whereby 1 meter distance was observed. When we were making requisition for the conference package, that was actually one of the core areas that we would really have it outlined for procurement, just to take part in that. And maybe for patient level, maybe meetings and such, the good thing with most of our facilities, we have trees, let me call them shades. So we'd meet a maximum of 12 clients if it is a group, whereby we'll just sit under a tree in an open air where client activities would take place routinely. Then additionally, what we did in terms of differentiated service delivery, we actually had more. We had quite a number of community ART groups coming up, so that we would only have one, and which was actually patient-led. So this actually meant that only improved in terms of differentiated service delivery in that context. Thank you.
Thank you, Praxidis. Hopefully you can hear me. Apologies, everybody. My sound cut out, which is ironic given the fact that we were talking about all the COVID adaptations that we've had to make over the course of the year, and needing to be in a virtual space. But thank you so much for those. I'm sorry to have missed some of your responses, but in our notes and our recording, we should be able to get that. Praxidis, one more question back to you. There was a question about, the psychosocial support being received as a response to supporting coping mechanisms. Dr. Zianda Makaba was asking if you have any interventions to address the mental health component and behavioral change communication for improved treatment outcomes as part of your treatment program as well.
Thank you, Lana. Sorry, I actually missed these out during the presentation, but what we did when they were joining in, we actually screened them for just mental health. We actually did a mental health assessment. And so far we have screened them twice at the initial, when we're just enrolling them. And thereafter, February this year, we also repeated. And we actually realized that quite a number of them had challenges. And to be specific, we identified 5 of them. And because of the challenges I had actually mentioned earlier, we were not able to support them at the facility level, but we referred them at the county referral hospital. So as a program, what we have planned just to mentor our facility, or rather our service providers, so that they have the capacity to support these clients. And we have already engaged the county mental health focal person, who is actually mentoring the facilities on the ground. And this is something we are really going to strengthen, because it was actually a challenge on our side. Thank you.
Thank you so much for that. You know, one other question I was wanting to ask for Isabel is whether, you know, when you were talking about the peer educator and case manager visits, I am trying to get a sense, and this might be also relevant to Braxides for your peer support group as well. I'm trying to get a sense of how structured the interactions and counseling provided to clients are through peer educators and case managers, as well as in your peer support groups. You know, could you speak maybe a little, both of you maybe speak a little bit to how, you know, how the interactions or each session is determined, the topics of each session are determined? Is it client determined, they introduce the subject, or is it sort of directed by the whatever, if it's a set curriculum, or is it sort of a combination of both? If you could talk a little bit to that.
Thank you, Lana. It's, oh, sorry, Isabella, you can go ahead.
No, it's okay.
Thank you. It's actually two-way, but just to mention that we have a treatment literacy guide that will actually help us take the clients through the basic things that they need to be capacity built on, so that they have the perfect treatment literacy in terms, just for them to be perfect in terms of their continuum of care. And before we go to the clients, we actually take the peer educators through the same, and also the healthcare providers. And additionally, the 2018 ART guidelines is so clear. It has all the components that a service provider can actually just take clients through the same. And additionally, clients, because I've said this two-way, clients will also talk about you know, their areas of concern and all that. If that is not captured, we'll go ahead and just have an appointment with them individually or as a group, so that we support them accordingly.
Okay, it's almost similar to what Brexite has indicated. For the KPSTAR project, our peer educators, they have flip charts, and with also basic information on HIV self-testing, PrEP, ART, condom usage. So we have those information as a entry point. We have what we call a minimum package. So they give that information. For case management, case managers are actually trained to do risk assessment. They also develop care plan, what is required, what is the next step for the client, and then also linking clients. So within the case management component, then they continue following up. They continue also re-evaluating the risk and still provide further support to also other issues that may come up, and also other issues such as psychosocial support or psychosocial issues that may interrupt treatment. So they actually do continuous risk assessment with the clients to ensure that the client is fully supported and the client adheres to treatment. Thank you.
Great, thank you. Seeing that we have 3 minutes left, I think that those will be our final questions, but just really appreciate everybody's participation on the panel, our panelists, as well as those in our who attended today's session on viral load. I know these were, three very distinct aspects or interventions within a program with different populations, actually. But it was really great to learn and highlight some of the work that you are doing. Really thank all of you for participating today. And unless anybody else has any final thoughts, from amongst our panelists, I think we can close today's session. So thank you once again. Any other final thoughts?
Okay, maybe for me, there was, I think, a question on HIV positive status, whether how do we ascertain that they are new HIV positive? So we have a screening tool. The facilities or the hospitals, whether be it private or public facilities, they have a screening tool where they determine whether the client was already on ART, and we also use the client information before a file is opened. We also look at the electronic patient management information system to look at whether the client has appeared once in the system. So that's how we ascertain whether the client is a first time client on ART. Thank you.
Great, thank you. Thanks for catching that, Isabel. All right, well, we are on the quarter of an hour, so I'm going to close this session. Thank you again, everybody, for your participation, and enjoy the rest of the conference.
Thank you so much. Bye-bye.